Hi guys, it's Dr. Sloan. I'm back. Um, just want to show you this inheritance pattern for cystic fibrosis. So if you look at this here, mom and dad are both carriers. That means that they don't have any sign of the disease. But when they get together, then what can happen is, depending on which of these alleles, each one of these is an allele, depending which one comes down and actually matches up with whichever one comes from mom, tells you the different possibilities here for the coin toss, so to speak. So again, 1 in 4 chance that your child will have this with every birth. So just because you've had a child and they do or don't have CF doesn't necessarily mean that the next child will be the same. This is really an important concept. Okay, so here's a question, and actually the answer is already done. Client wishes to become pregnant, but has a family member with CF. She asks about the need for genetic testing, and the goal is that you want to get them to a genetic counselor so that they can do that pedigree and they can go back and look, and then they can figure out who needs to be tested. So sex-linked pattern diseases, now these are different, right, from the autosome. So here you're looking at things like, remember, XY is male and XX is female. And the incident of an X-linked recessive disease like Duchenne muscular dystrophy means that the father is not affected, but the mom is the carrier. And I just want you to think about this. If there's a sex-linked pattern and you are the parent that is the carrier, how do you think they will feel as they learn about this and find out that they've passed on a disease to their child? And that can be very, very difficult. So something to think about. Diseases that fall in this category are hemophilia, which is interesting. Since it's a problem with the blood, we don't think about it being a sex-linked pattern, but it means that the disease is coming from those genes that determine sex or gender. So again, here's hemophilia. It's just more of a description of what hemophilia is, and I'm not as concerned that you know about hemophilia itself. But it's a good example. And if you look at this sweet little chubby hand, that's a bleed that you're seeing in those fingers and in those knuckles. So all that dark in there that's blood, and the swelling in there is from blood in the interstitial spaces. And it's probably from an IV stick or a poke of some sort. What makes me sad. Okay. Here's the pedigree of hemophilia. So again, mom is the carrier for the hemophilia gene, and it means down here that it's going to pass on down to the son. So a lot of parents who know that they're carriers for hemophilia, they will use all kinds of things, at least they did in the old days, to try to predict whether they were going to have a boy or a girl and try to, quote unquote, become pregnant with a girl versus a boy. Now we have genetic testing, but depending on your beliefs, you may find out that your embryo is a boy and has hemophilia, and then you have decisions to make at this point, and it's not an easy thing. So here's the client with family history of polycystic kidney disease, an autosomal dominant disorder. And the client says, I'd like to be genetically tested, but I don't want my family to know. And what's the answer to this? And that is, confidentiality will be maintained. This is protected health information, just like anything else that we do with patients. And so this is an information that has to be given to someone else. And that can pose some real ethical issues when you get into genetic testing. So just so you know, I just touched on this a little bit, but there is a Genetic Information Non-Discrimination Act that basically says you're not allowed to discriminate against somebody financially or in any other way based on genetic testing. So for instance, if you get genetic testing done, they can't, all of a sudden find out that you or your child has some disease and say, oh, we're going to drop you from the insurance. That's against the law. So that's good. So you want to make sure that you know that so that you can advocate for families in case employers do say something like this. So again, remember that people have a right to know and a right not to know. And so, for instance, in the case of Huntington's, where the diagnosis is so devastating, people have a right to say, you know what, I don't want to be tested. I would like to just live out whatever time I have left and not have that shadow hanging over my life. So, again, the final decision is the patient's, and as nurses, we need to be supportive of a person's autonomy and the right to make their own decision, even if we don't agree with it or we would not do the same personally. Genetic testing's done for a lot of things. It could be to, prenatal testing, pre-implantation testing, where they're actually testing embryos that have been created in a test tube or in a laboratory environment, looking for screening for particular diseases, predictive testing, where we're trying to figure out what are your odds of having a certain disease, or forensic testing, which is what we see all over television. Also, we do newborn screening, and you'll see that each newborn that's born gets a certain panel of tests that's done. It's paid for usually by the state. And the rationale is that if we can get this testing done early, we can identify diseases that might be present early. Then having that knowledge can really help with planning for care and services down the road. Again, you cannot use that screening to drop their insurance or deny them services that they are entitled to. So genetic testing. Right now the big thing is mostly a buccal swab, means just a swab on the inside of the cheek, but we can do it with a lot of things: blood, hair, skin, amniotic fluid. You see the things on TV like, so-and-so smoked a cigarette and threw the butt in the garbage and they retrieve it, do DNA testing. The thing is, though, we have to know that once we start doing this testing, in some ways, we're opening a black box of unknowns, and we need to be prepared for what happens when we do these tests. And I think, genetic testing's been around for a while, so we're starting to have more and more discussions about that, but something to think about. So when teaching the client family about genetic counseling, what information does the nurse include in the teaching plan? And the answer is that diagnostic genetic testing determines the risk for a specific disorder. The rest of these are not true. So anyway, just keep that in mind. So what's the role of the nurse? We've already talked about this a little bit, but you want to look at medical history. You want to identify genetic concerns. You want to really help them with the psychosocial aspects of coping. Maybe they get the results back, from, the cancer lab that says that their tumor is not susceptible to some of the treatments that are available, and that there really is not a good choice for chemotherapy. That'd be very, very difficult and something that you will need to help support your families through. Mitochondrial disease, I just want to give it a mention because you will see this if you work in pediatrics. Now, one thing that's really interesting here is you have to remember that the mitochondria has its own DNA not the double-strand helix DNA. It has a ring. It has a ring of DNA. And it is separate from what you see in the nucleus of the cell. And in some cases, there can be mutations and other changes in that mitochondrial DNA. And it often results in these sort of non-specific, hard to measure, define, diagnose problems. And you'll hear the term mitochondrial disease, that someone has mitochondrial disease. So you can just educate yourself on that. I just want you to be aware of it. Mitochondria are little energy making factories. So if we have mitochondrial disease, the person may not be able to make energy as much. And again, it really manifests itself in a lot of very interesting ways. Epigenetics. This is really cool. Epigenetics is really, what are the environmental things, lifestyle things that affect our genes? So we might have genes sitting there that don't do anything, but because we, eat at McDonald's every day for lunch, that is an epigenetic influence that can turn a gene on or off, or can affect how this can be expressed. And the best way to learn this really is, the slide is good, but I would really encourage you to watch this YouTube. I want to say, I think it is about 9 minutes, and the guy is kind of strange, but very, very funny, and does a great job of describing what epigenetics is. It's really probably, just back to epigenetics, really something that we, as nurses, we really can influence as we teach people about healthy lifestyle and, avoiding risks and exposures to things. So something to think about. It's probably the one area where we can really have an influence that may actually change the trajectory of someone's health. Pharmacogenetics, again, it's really studying how genes affect an individual's response to a drug. And if you look at this slide, I think it's great. Let's say you take a medication, and you can see there with the little double-stranded helix DNA, somebody might take the drug and it works great for them. Maybe somebody else takes the drug and they only get a partial response. Maybe somebody else takes the drug and they have a response to it that would indicate, that they're really sensitive to the drug. Or even worse, you have genes that really dictate that the person's going to have a serious adverse drug reaction to the drug. So there's 244 pharmacogenes associated with adverse drug reactions, and 28 have been listed by the FDA as pharmacogenomic biomarkers. Now, do we always test these? No, I think it's costly. It's very costly. So again, kind of depends on the drug and the person and why we're using it and what the risks are with that ADR. So again, adverse drug reactions, could be that, I love this slide, you have patients with the same condition, right? But because of their DNA, it really determines how they're going to respond to the medication we give them. So something to look at. And then also some of those epigenetic things may play in as well. Things like lifestyle, age, organ function, other therapies that they're taking, the diet that they're on. So again, something that we'll study maybe a little bit more as we move forward here. The future is amazing. We know that there are lots of gene therapies on the horizon. There's some gene therapy now for cystic fibrosis, not for all types, but for people with certain genetic mutations in there. We're going to create dosing guidelines based on people's genetic information. We can do individualized pharmacotherapy